So good afternoon. It is now, about 5 after 2. Thank you all for joining this meeting. The first thing we're going to do is we're going to convene the City of Temple Benefits Trust for Thursday, July 15th, 2021. Item number 1 is to consider adopting a resolution authorizing the purchase of employee insurance policies from the following vendors for FY 2022. Medical and pharmacy insurance plans from Scott & White Health Plan of Temple, dental insurance plans from Standard Insurance Company of Portland, Oregon, vision fully insured policy from the Standard Insurance Company of Portland, Oregon, flexible spending accounts, dependent spending accounts, cafeteria 125 health savings accounts, administrative services, and consolidated omnibus budget reconciliation act administrative services from Connect Your Care of Hunt Valley, Maryland. And lastly is the basic life, voluntary life, accidental death and dismemberment, short-term and long-term disability insurance, and accident, critical illness, and hospital insurance from Standard Insurance Company of Portland, Oregon. Ms. Raymore.
Hello, everyone. I'm happy to see you all today. Is there a clicker?
Brian will be your clicker.
Okay, so I'm very excited this year to present the benefits that we're proposing. Benefit year, as most of you may know, starts October 1st every year and it runs through September 30th. So today we'll be talking about those proposed plans for the upcoming year, and I'll mention anything that's changing for all of you. First of all, medical plans. Our medical plans will remain the same 4 plans that we have had historically, which is 2 high deductible plans and 2 PPO type plans. One is a preferred Scott & White network, and one is on a nationwide network. We went out for RFP back in April of 2019. We've been doing renewals since that time, and I'm excited that this year when we conducted our renewal process, we were able to get a reduction in our premiums on the employer side of $229,000, which is very significant if the world. Generally, there's increases every year. So every time I can get a decrease, I'm super excited. So we got that. And then the only other change I want to mention on the last slide is that we are changing from Aetna to Cigna as the provider of the nationwide network. You may recall it was Cigna, it changed to Aetna. It's going back to Cigna. That is something we can't really control. We were notified by Aetna that they can no longer manage the plan. For dental, we're recommending the standard. We currently have United Concordia, so this is a change. We just went out for RFP in June of 2021, so about a month ago. Again, I'm excited that we're able to reduce our premiums here by 17.5% on dental, which again is a great feat for us to accomplish. And this one has a 2-year rate guarantee, so our employees will be able to enjoy those discounted lower rates for the next 2 years. Okay, might have to click it.
I think I messed it up. Hold on just a second.
Okay.
Okay, now it should work from now.
Okay. The vision plan, we will have the same plan we have had for the last year or so, which is the standard. There's one plan that's offered. We did go out for RFP last month in June. We were able to negotiate a 19.5% increase in premiums. It is an increase on this one, but I did want to point out that the highest dollar amount monthly that someone would pay is if they're in the family plan. Their increase is going to be $2.37 per month. That's because vision is historically like a lower cost type plan. But that 19.5% increase equates to that amount. We have a 1-year rate guarantee. For the basic life, supplemental life, and accidental death and dismemberment, we're recommending renewal. We went out for RFP in April of 2019. There's no rate increase because we are in a rate guarantee right now. We still have 1 more year of rate guarantee remaining for the FY 22-23 year. For disability, it's the same as the previous screen, which is the standard. We're maintaining the same plan, a renewal with no change in benefits or cost, and we are still in a rate guarantee with 1 more year. That one. Our FSA, HSA, and COBRA, you may recall we changed that last year. We went out for RFP in May of 2020. We were very lucky to get a 5-year rate guarantee when we went with them, and our rates were actually reduced from what our previous vendor we were paying them. So we still have 4 years left on this one. So again, this is one that's saving us some money here. Additional insurance, these are the worksite benefits. We currently offer accident, critical illness, hospital indemnity, and cancer. We currently have Guardian. We went out for RFP last month, and we're recommending a change to the standard. One change here is that cancer will be included with critical illness. There won't be a standalone cancer plan. If an employee currently has a cancer plan and wishes to keep that and have the cancer coverage under critical illness, which comes with it automatically, they can port their current cancer insurance. They're able to do that and pay for that themselves. This is a wholly paid, these policies are all paid by employee only. There's no employer contribution. We were able to secure a rate reduction for all employees for every employee that enrolls in any of these plans. So every plan at every tier has a rate reduction. The percentage varies depending on their age and what coverage level they pick. We do have a 2-year rate guarantee here. That's just missing from the slide. And that's the end of the presentation for the benefits for next year.
Good, thank you. Council, any questions for Tara?
Bad news.
I try not to bring that.
Right. If there are no questions, then we will move on to a vote. I'll entertain a motion on item number 1. Have a motion by Trust Member Morales, a second by Trust Member Walker. Ms. Elder, if you would please poll the benefit trust.
Trust Member Walker. Trust Member Williams.
Aye.
Trust Member Long.
Aye.
And Trust Member Morales.
Aye.
Mayor Davis.
Aye.
I guess. I don't know.
Trust Mayor. You can't say those two things together. All right, very good. That resolution passes. I'll now adjourn the meeting of the benefit trust and move into our regular work session. Citizens who desire to address the council on any member listed on the workshop agenda may do so if they've signed up previously. There are none. We'll move on to item number 2, which is to discuss as may be needed in the regular meeting agenda items for tonight's meeting. Council, is there anything that we need to discuss, or staff, is there anything that you need to clarify?
Mayor, item number L on the consent agenda, I would request that you consider order for the consent agenda for voting purposes. Person Morales to abstain for perceived conflict of interest. And then just as a note, she has also filed an affidavit of extension on item number 5, also for a perceived conflict of interest.
So we're pulling L for voting purposes.
Yes.
Item 5.
Which is the CDBG public hearing. And
Yeah. I'm sorry, it's right there in front of me. Okay, anything else? All right, then we'll move on to the second item of the work session is to receive a presentation on the civil service market study.
Hi, it's me again. So my 2 favorite subjects, benefits and compensation. Okay, so you may recall that we do a market study every year, one of the each, it's alternate year. So this year was the civil service market study. So these are the market peers that we looked at this year. Bryan, Cedar Park, College Station, Georgetown, Harker Heights, Killeen, Round Rock, San Marcos, and Waco. So these are the results of the salary study. So I'll kind of walk through those with you. We look at the positions from police cadet all the way through the deputy police chief. Those are all civil service positions. So you'll see in the first column what the market median is. The next column over to the right of that is the Temple current minimum, for that rank. And then what the dollar difference and percent difference is. So you'll see that the greatest difference currently is in the police probationary rank. You'll also see a star up at the cadet. The reason for that is we only have 2 cities in our market that have a cadet position. Most cities have like a probationary position, but they don't have 2 ranks there.
So probationary, obviously, that's a brand new officer.
Yes, and cadet for us comes in, that's brand new, and then they go to probationary, and then they move on to police officer.
Gotcha.
In a lot of cities, like I said, they just have probationary and then police officer. You'll see the police officer rank shows approximately 8.6% behind market. The corporal is about a little less than 1%. That's another one that only Cedar Park and San Marcos have. So a corporal rank is not very common. And then the sergeant is at approximately a little less than 2%. The lieutenant is a little less than 5%, and the deputy chief position around 8% behind market.
Tara, do we never include Belton as a neighbor city because it's so much smaller?
There's a whole rubric that went into the process of selecting the cities that took into account factors such as population, so a lot of different factors, so they're not included in the study.
Well,
Because
right.
they fell out of the.
Okay.
A few of the factors that impacted is population.
We look at items such as education, certifications for intermediate, advanced, and master police officer, bilingual pay, hiring incentives, field training officer, are they offering a standby pay, if they're a shift differential. So those are the results that you'll see here on the screen. You'll notice some of them show like a standby pay that we're 100% behind market because we don't currently offer that one. The shift differential, shows we're right on market. There's a couple stars at the bottom that you'll notice. The hiring incentive, there's 3 cities that currently offer that, and those are College Station, Killeen, and San Marcos. And then the shift differential is offered by San Marcos and Killeen. So the biggest differentiation for the ones that we currently have are going to be the field training officer, FTO pay. And then if you look up at the education, the master's degree at the 20% behind market. Okay, turn it off again. I just wanted to give some recruitment facts. Many of you in the room may already know this, but it's extremely difficult to fill police officer positions. And that's not just a problem for our city, that's a problem nationwide. I was recently in Georgia and riding around different cities and areas around the Atlanta area, I saw many signs and billboards for hiring of police officers and incentives and training programs. So it is truly a nationwide issue. As of the time when I created this presentation, we had 16 vacancies. I believe we're still at 16. 17, okay. We had 32 candidates come to our last entrance exam. We hold entrance exams, just to give you an idea, for police. When I first came here, we do it about twice a year. I believe since last October, we've already done 3. So we're doing them much more often because we aren't having people show up, and then people that do show up, we aren't having many pass the exams, for example. Out of that 32, only 12 passed the written exam. There's only 6 after that date that are still being currently evaluated, going through the screening process. And then we've only had 6 new hires for the whole year 2020 and all of 2021. So that's all that we've had. So again, there's some things that we're doing, and I think you've heard of some of those recently. Come up with the company Epic that we've recently gone into contract with to try to help us with recruiting efforts.
Do most candidates apply the number of different cities, people that are interested in becoming an officer?
I think some of the cities around us when they're recruiting, yes. So like if Colleen's doing it at the same time as us, we'll see a lot of candidates going to the same city.
So to have 32 applicants, but then only 12 show,
Mhm.
right? You're losing 60% of your applicants.
Well, 32 actually showed, 12 passed the test.
Okay.
Registered for the test, we have like 60. And then out of
And-
60, 32 show. And so it seems like, ever since I've been here anyways, about 50%. So we have half of them show up that register, half of them pass, and then half of them get eliminated. And then, dwindles down, and you have so many vacancies, you're just not gonna catch up.
Wow.
So again, there's some things that we're trying to do.
Especially being 15 behind, 50% behind market.
Yeah.
That doesn't help.
That doesn't help either. So some of the things we're doing is right here on the screen that we're recommending that will help with that, we hope. One is eliminating the cadet rank. We notice, as you noticed, that not many cities have the cadet rank. That's not a civil service position, so to speak, so we are able to eliminate that one without having that to need to be approved through like the meet and confer or anything, because it's not a civil service position. Having our total probationary time, though, it will increase to 18 months. Currently, they're in the probationary rank for about 12 months, and they're in the cadet rank for 6 months. So this isn't changing the total time that it takes for them to become a police officer. It's just putting them in one slot for the whole time, the complete 18 months.
Is that time period similar to the other cities?
That is very
Yeah,
similar,
okay.
yes. Cities that offer an academy process, which is what we do, that first 6 months period, then they generally have a year after that probationary. Some cities don't offer the academy though, and they only
Right.
bring them in after they've gone through one.
Through somebody
That is
else's
a-
academy?
Somebody else's, or some of them pay and go to one that's a paid academy, so just different types. We are recommending adding a 1-year step for all ranks. For all of the ranks that we currently have, from the police officer all the way through the deputy chief, they promote or they get to that spot and then they wait 3 years for a pay increase. So we're recommending adding a 1 year. So it'll be 1 year, 3 years, 5 years for their step increases. The other thing is we're recommending setting our starting pay for our probationary police officer to the market median rate of police officer, not their probationary level. So that'll put us a little bit higher at our probationary level than what the market is, but it'll have our starting rate at what the police officer market median is. This is what the chart looks like. I'm sorry if it's hard to see. Try to get it as big as I could on the screen and get it on the screen for you. But essentially, we're currently paying a cadet when they come and they're hired and they first start, they're making about $46,000 a year. After that 6 months, they go to $48,500. We're recommending that we don't have the cadet rank, and then the probationary, which is where we would start then, would be at $60,350 annually. And then they'll be there for 18 months, and then they'll go up to $60,825. Right now, when they come off of their 18 months probationary after they're done, they go to $55,000. So as you can see, that is a good increase, and I think that puts us at an advantage in the market for competitiveness. And you'll notice that 1 year promotion at each of those ranks, which we don't currently have. The only one that doesn't have that and actually is losing a couple of steps is the corporal rank. Again, the corporal rank is very uncommon. We're one of only 3 cities that currently have that. And so that's the recommendation for there. The corporal rank really is a point where you want officers to promote there and then get that lower level supervisory type experience and then promote up quickly, hopefully to the next rank once they're eligible. Are there any questions about police before I go into fire? Okay, so for the fire department, here's what that looks like. So again, the cadet rank isn't very common. Only the city of Bryan currently has a cadet. Most cities do have probationary. Because of that, it looks like we're above market at the 21.6, but it's because we have one comparator. Probationary, we're behind market about 6.4%. And that one is actually the biggest delta that we have as far as market is on the probationary rank. You'll see firefighter, we're behind market by about 5.7 as well as the driver. The captain is around 5%, the battalion chief around 4%, and the assistant fire chief around 6%. Here are the incentive pays for fire. So we looked at education again, their certifications, which are the EMT and firefighter certifications, bilingual pay, hazmat, and training officers, one that we don't currently offer that we wanted to look at. The items that have the 1-star asterisk, which is the EMT advanced, only 2 cities have that, and that's Georgetown and Killeen. And then only San Marcos is currently offering that training officer fire incentive pay. I did just note on here for anyone's information that wanted to know that only Killeen and Harker Heights have Kelly days currently. So that was something that we were looking at as part of the study, if it was common for all of our peers to have Kelly days, or how does that look in the area, but there's just those cities listed there. And if you want an explanation on Kelly days, I can try, but I'd probably let the chief give you the explanation because you can probably do it better than me. Do you want to speak to that at all?
Sure, I can. So what a Kelly Day is it would be a planned day off in lieu of a FLSA overtime event. So right now, the firefighters just kind of built into the schedule because of the 24-hour shifts, get around 14 hours of overtime pay on 2 of their checks, and then 1 of their checks there is no overtime pay. What this would do is on those larger checks, it would, instead of giving them 14 hours of overtime, it would give them X amount of hours off where they just wouldn't work, and so they would not collect overtime. But that would also include hiring, I'm guessing, I haven't really looked at it, but at least probably 10 to 12 firefighters to cover those days off as well. So there's a cost to it as well. It's just not given for.
How did the name originate?
So that is a good question. It's been called that since
Kelly.
it's been called that since I've been in the fire service.
Probably a fire chief.
So somewhere. It may be from a lawsuit.
Payroll.
Yeah.
Which did the firefighters prefer? Or it's a mix? They really have money.
Because they can take the time off when they want to. This forces them to take the time off.
Yeah, it's a plan, but it's not when they want it necessarily. It's-
Yeah.
It originated from Mayor Edward Kelly.
Okay.
Oh,
Where the mayor.
Chicago.
okay.
That's a
Please do not name anything after me. It's gonna make so
Oh,
much.
wait, Tim, just wait.
So we have just one recommended pay chart update, which would be a change to their structure, and that's adding a 1-year step for all ranks for fire. So it would be consistent in fire and police that they would receive an increase after 1 year in each rank. And I love that fire truck. Here's their pay chart, and so as you'll see, currently a cadet comes in at $46,974. That would be going up to $50,000. The probationary comes in at $49,000, and that would be going up to the $52,000. And then civil service currently $51,000 would go up to $54,000 down the line there through the ranks. And those are all based on market release. Any questions on fire?
I have a general question. So we talk about, people sort of matriculating up the ladder, so to speak, pun intended. Can a police officer or someone in the fire department, I guess they can reach a point where they can work up through the system and then just stop, right? Stop being promoted. And then does that end up creating sort of a glut at a certain position that then keeps newer firefighters or officers to be able to work up themselves? Some of those guys that are staying in one spot, or gals that are staying in one spot, end up creating a system sort of downstream of problem?
There could be a pay compression issue if let's say a firefighter, they stay in that position for the 14 years. And then someone else gets hired and they're there and they're 14 more years. They've been here now 28 years and they're at step 14. Someone could have caught up with them that came in midway through their career.
Does that end up creating a problem though within the department that enough people are doing that it would maybe hinder others from promoting through, or just some folks hang out there longer than maybe they should and it's not a problem?
I mean, most of the ones in the fire department that do it because of choice. I was trying to think, I think in firefighter, I've got maybe 3 or 4 that would be that way, that are gonna be career firefighters.
Yeah.
And that's, they're choosing.
But it doesn't create a problem.
No.
Okay.
So the promotions, the vacancies in the hiring happen, they happen. And
Sure.
it's regardless of who's promoting us. So in
So
the
theoretically, somebody
unlikely
could
chance-
pass.
yes, in the
Oh,
unlikely
yeah.
chance that nobody from the rank below wants to promote and qualifies for promotion, then you would still have a promotion.
Okay,
I don't know that, I have not ever seen that happen, but it could happen. If,
Okay.
you had every lieutenant or every, captain say, I don't want to promote, then
Yeah, so,
they can be passed.
okay, good.
yeah, by civil service rules, what would happen is like, if we had a battalion chief opening and no captains took the test, we would open it to fire drivers, and then they would get a chance to jump the rank.
I got you.
And
As
then,
long as there's that ability that nobody's creating
that's
a
correct.
dam, so to speak, then, okay,
Yep.
good.
So health plan comparison, this is something that we've been doing. I pretty much do it every year, but I present it to you on the year of civil service. But I want you to know when we're doing our renewals every year, we do look at comparison from other cities. So here, what you'll notice when you see these differences, basically the high deductible employee only premium, we have ours at no charge. The market median is 15, which means we're doing better than the market. The employee and family premium for the market is $340. We're at $175. So again, we're doing better than the market. Our HSA contributions that we put into the employee's account, if they're employee only, it says per paycheck, but for this one, it is per year, which I have down at the bottom, yearly contribution. The HSA city employee only for the market is $750 and we're at $1,460. For the employee and family, the market is $1,225 and we're again at $1,460. So there, it's a positive percent, but that's the amount that we are above the market with how much we're putting into the accounts. The non-high deductible premiums, market is at 38 for employee only for our lowest cost plan, which is the preferred network. We're at $30. So again, we're doing better than market. And then our non-high deductible employee and family premium, $458 is the market and we're at $350. So again, we're doing better than the market. So our health plan is pretty healthy as far as benefits go. Are there any questions on this one?
Why are we doing so much better?
You're
How?
just that good?
Seriously. I know you're wonderful, but how is it that we're doing?
Tell
so
us how
much
you're
better?
wonderful.
So one of the things that you again have to keep in mind, you have to negotiate every year. You have to try to negotiate and keep your rates lower. I found, at least in my experience, that a lot of times with plan renewals, they'll send you a renewal. And some people just accept the renewal. So you have to go back and say, no, I'm not going to accept that. I need you to negotiate that lower and tell me why you want more money. And you've got to do a lot of that, kind of like buying a used car.
Sure.
So you've got to actually do that work. That isn't always done. Sometimes the renewal is just accepted. So that's one of the things I find, because I talk to like other HR directors and they're like, oh, well, we just get it from our consultant and we just say, well, we got an increase. And I'm like, no, go back and tell them to show you the data of why. The other thing is responsible usage of the plans, right? So that's on the employee. So our employees do a great job of not overusing the plan. Don't go to the ER when you get an ear ache, that kind of thing. So we don't have high claims, which again, when they're looking at our renewal, they're looking at how much did we cost them to operate. And if we're overusing the plan, if our employees are being bad stewards of that plan, then that's going to impact it. So it's not really all us. We're doing the negotiating on this side. But if we have a bad plan year because all our employees run to the ER, then that's gonna impact it too. So the employees do a lot of the legwork to make sure that we don't have premium increases and we're able to stay competitive and keep our costs low.
Also, probably 3, maybe 4 years ago, we adopted a plan structure that was, that included some high deductible, HSA eligible plans, and you can see in Tara's information that we were aggressive in the contribution towards those plans from investing in the HSA, which was based on the cost difference between what it would have cost us to fund a fully insured, or I'm sorry, not a fully insured, non-high deductible, so like a PPO plan, for example. But that allows more responsibility on the employee, but so less hits the health plan up front. But we've also, invested in those accounts so that our employees have the money in their HSA accounts to cover those costs. And I think that's also over a several year period has helped us manage our costs as well.
It also drives employees to a less expensive plan. Drives healthy employees to a less expensive plan, typically.
And they're less likely to go use it.
Right.
They have to use their HSA dollars.
Okay.
That's right.
Interesting.
Any additional questions on the market study?
Again, moving in the right direction, always. It'll be interesting to go over police and fire compensation when we dig into it in the budget to see kind of where we're going. So, anything else? Okay, thank you, ma'am.
Thank you.
Item 3 is to receive a presentation on the industrial pretreatment program fees and surcharges. Mr. Muppet.
Hi, thank you, Mr. Mayor and Council. This presentation is to go over the industrial pretreatment program fees and surcharges that we are proposing. The industrial pretreatment program protects the Temple's wastewater treatment plants from disruption from pollutants and ensures that the wastewater treatment plants can handle future development, particularly industrial users. There are many parameters that are monitored. 3 pollutants that are vital to Temple's wastewater treatment plant operations are the BOD, TSS, and ammonia. And the industrial pretreatment program affects all industrial users, but the surcharges only affect industrial users that discharge over the domestic loadings. And the goal of the surcharge is to lower pollutant loadings at the wastewater treatment plants. Proposed permit fees are based on comparisons to programs from cities within our region. The proposed monthly surcharge fees are based off actual costs of treatment. The city enlisted Perkins Engineering to study surcharge cost allocations. Contributors for costs include power, sludge processing, labor, and capital costs. The surcharge will only apply to loads above the domestic loading. So the calculation is, you can see, we subtract the domestic loading for BOD is like 250, TSS is 250, and ammonia is 30. So industrial users do not get charged for the domestic loading in the calculation. So we did a comparison on surrounding cities with industrial procurement programs. You can see the permit fees. Most everybody that we were able to get information from had permit fees. You see on Temple current, we have not charged the permit fees. We are proposing the information on the far right column.
Can you go back to that?
Sure. I'll break this down a little bit better in the next
Okay,
couple.
okay, go ahead.
Okay. The monthly surcharge fee Also, we checked surrounding areas. San Marcos, it looks like they don't do a surcharge for BOD, TSS, and ammonia, but they do a surcharge for COD. Waco is in development. They're doing some research, but the remainder do have surcharge fees. And then Temple, right now we don't have surcharge fees. We have a kind of surcharge fee that we use only for enforcement. So if an industrial user violates 3 times in a row, then we have this small surcharge fee, and it's not impactful at all. It's very, very minimal. So we are proposing the fees to the right, all the way to the right, which is a calculation of those constituents that we talked about earlier, the electric, the power, the labor, the sludge costs. So currently we have 8 industrial users that are significant users. We have 3 that are categorical users. The difference in a categorical user and a significant industrial user is a categorical user has federal limits, and a significant has only local limits that they have to meet. And we did meet with each of these industrial users to discuss the proposed changes. There were no significant concerns. Most of them are familiar with these kind of charges because they have industries in other cities that have the same kind of thing. So our proposed for SIUs is $50 a month, and CIUs $75 a month. The only 2 industrial users that would have had a service fee in 2020 were Waste Management and BJ's, and that would have been the impact of the service charge for them. And then the monitoring lab costs would be an annual $1,000 to $2,000, depending on the SIU or CIU status, that would be passed through to each industrial user to pay. So over a year, SIU's revenue would be $4,800, CIU's $2,700. Contributory IUs would be $21,000, looking at 2020. And it's interesting to note that we pay the Reservoir Authority $1,280 per month per permittee, per permitted industrial user. So these fees are just a drop in the bucket, but it is helping us to cover some of the costs. To revise the IPP ordinance to include these services, these fees and costs, we have to amend Chapter 38, Article 5, and the new Article 10 is proposed also, and then have a supporting fee schedule adopted by resolution. And begin collecting fees, proposing October 1st, 21, and surcharges October 1st, 22. This is the list of our industrial users currently and their designation. Anybody have any questions?
A lot of numbers up there pretty quickly. Are the fees going to cover the cost of treatment?
Now, if you remember, we've talked a little bit about this before, so just a little bit more background or refresher. Think about Dozier wastewater treatment plant. We have very limited capacity to accept BODs. So as we continue to speak with industrial clients that are considering our community, that's a choke point, pun intended, in our ability to serve for wastewater collection. So really the goal of this program, while we are proposing some annual permit fees, really the goal is not a revenue generation impact. Our goal here is really to encourage industries to do on-site pre-treatment so that they're treating their waste to the domestic loading, so that when that goes to the treatment plant, we have more capacity to continue to grow our industrial base. And so that is one of the reasons that we're proposing the surcharges not to go into effect until October 1st of 2022. So a little bit over a year from now, because what we would love to see is industries like, for example, BJ's to take on additional on-site treatment. We would actually prefer they don't pay the surcharge fees, but instead do pre-treatment that would allow us to free up additional capacity at our treatment plants. We have, from a flow standpoint, we have capacity at Dozier, but from a BOD standpoint, we do not. So this is just one of many tools, and Public Works, through the leadership of Don and Kenton and Carrie, have done a lot of work over the last year, 18 months, 2 years on different strategies. You'll recall we're pursuing I'm going to get the terminology wrong, but a major amendment through TCEQ to expand or to amend our local limits. We never permitted the Dozier expansion that happened several years ago for additional constituents. So we think we can achieve some benefit there. We've also done a non-substantial amendment. Substantial was the word I was looking for. We've also done a non-substantial amendment that was really the Public Works team worked really hard on to reallocate some of our current capacity, and that saw us with some success and ability to serve additional clients that we've worked with over the last year or two, and has resulted in significant investment and job creation for our community. So this is just one of the several steps and strategies that we're using to make sure that we can continue to grow our industrial base and serve our customers into the future.
I did have an extended talk with BJ's about this change. And these two industry users are currently doing no pretreatment whatsoever. So BJ's is going to look into doing some pretreatment that will help those numbers come down. And so that's very promising that this might help us for some of that BOD up.
And I appreciate the suggested approach from Public Works, because it does continue to give the industry the option. If they choose, they want to still send the, not pre-treated waste to the wastewater treatment plant, they still have that option. But they can just do an evaluation, with this information to understand if it's better and more cost effective for them to treat on site. And if you go to the slide that has the administration cost, so I mean, that we pay, a significant amount more to administer the program than we're passing on here. We're just looking to encourage on-site pretreatment versus relying on the wastewater treatment plant to handle that.
I know that BOD capacity has been an issue for some of the industrial park, economic development type work. If everyone was to be in compliant and that their load met the domestic, or that their discharge met the domestic load, how much of an impact would that have on BOD capacity?
So
I mean, does it really move the needle to do all of that?
We're actually about ready to try and get something through TCQ that's going to really affect that and free up a lot more than we currently can.
Administratively?
Right.
Yes,
because of just the way our permitting is.
Right.
So we're doing it's called a T-bill, technically based local limits bill. We're going to add something in there that frees up a lot of that BOD. So
because the application wasn't made previously? Is that?
that's
You're talking about
how it was made. It's just
It has to do with how the program's managed as well. We're talking about managing a program where you encourage a user to make their waste more like a domestic stream.
Mhm.
So in doing that, if they can meet that mark, there's two pots that you take your BOD loading out of. One of them is our domestic BOD loading, and one of them is your IPP, so your industrial pretreatment program loading. If they can get their waste stream down to a level to where it's like a domestic waste stream, then they go from the industrial pot into this domestic pot, and that is a little more free with what we have the opportunity to play with there, and it leaves the industrial pot, so to speak, as for those who particularly can't get to where they need to be, and they have to be in that portion.
in volume has a part in there too.
Yes.
So if you have a high volume discharger like Niagara, even if they get to do the domestic loading, their volume in the pounds is so massive that takes a huge chunk of our BOD loading.
Is this something that we are, let me back up. This is basically grief to me, but struggling with it. Are we looking at this when we're looking at potential companies that are thinking of coming here?
Yeah, so, for example, when Niagara, wanted to, so the bottled water, plant doesn't have a significant BOD component, but what's called an aseptic plant
Right.
does. And that was a big, challenge for us to work through with them because we were down to, at that point, 645 pounds of remaining BOD capacity. That was before we've been able to implement some of the strategies that we've worked on the last few months. But so again, we feel like this program is an additional ability to encourage our existing industrial users to lower their discharge so that we have more capacity for future. And I'm probably making it more simple than they would prefer, but that's in a simplistic way. That's
But we look
the
at,
goal.
we're looking at potential discharge, let me use the word usage or discharge amount when we look at possible companies that are looking at to come here.
Right,
Yes,
yes.
yes.
Because we only have so much capacity,
Right.
and we have a requirement to stay under a certain capacity at our treatment plant. So if we don't have any capacity left to offer, then we have to say no. And, I don't like to say no.
No, I do know. Except to some of us. And when there are dollars attached to it.
And there are things that can be done by the user on a relatively small scale to really be very impactful on what that end waste stream is. And like Carrie pointed out with BJ's, they're already thinking about what those things are to help them get to where they need to be. And it helps them, it helps us at the end of the day.
A few years ago, as I recall, Temple Bottling would have, if we had a program like this in place, Temple Bottling would have been in a surcharge category. But they've implemented a lot of technology, a lot of pre-treatment on their site. So today, under this proposed program, they wouldn't have any surcharge that they would, if they have similar, waste and continue to treat it. And BJ's is similar in the processing, not the same, but similar. Right. So they could, if they implemented that type of process on site, you could see them come down significantly. And then again, that just allows us to have additional capacity without millions of dollars in capital projects to expand the plant that hasn't yet reached a flow standpoint that would require expansion.
What does it cost? What will it cost, or ballpark? What does it cost BJ's as an example to do what we're talking about? Is there any upside that we assist with the cost of retrofitting, or whatever the correct term is, a company to do that because it increases our capacity? Again, if that's the correct term.
I mean, we've worked very closely with BJ since they've been in the community. At some point, they were even in a violation status. So we've been very working with them very close. I feel like we've been a good partner in what we're doing. And so what we're encouraging our people like BJ's, for example, to do is to take a look at what that trying to get to. So we estimate that they would have an impact of around $1,700 a month. So, this will have a little over a year before this will go into effect. So they'll have plenty of time to make the evaluation about what the cost effective approach for them is and implement if they choose to treatment on site, they'll have to do that before they would be in a position to have to pay surcharges. Which is why we're recommending the October 1st, 2022 date as the date that the surcharges would go into effect, so that companies have that year to determine if they want to make improvements and to get that done.
And again, there's no upside to the city considering helping X company with the improvement so that they don't face the surcharges, and it increases our, again, I use the term capacity.
That's a policy decision. We are already, these industries are already subsidized by the larger rate base because the cost of administering the industrial pretreatment program exceeds what they pay. So but you could, if you wanted to. That's not, again, staff's recommending, a surcharge approach that gives time for them to make a choice and make a good business decision for them. But that is a policy decision that we could explore if that was something, you wanted to consider.
Well, I have the remotest idea whether I want to consider it. There's more than one way to cut pie. That's all I'm suggesting.
Yes, ma'am.
That it? Any other questions? Thank you both very much. Move on to item number 4, which is to discuss a possible property transfer agreement with the Temple Community Clinic for an approximately 1.2 acre city-owned site. Address is 915 South 31st Street and 1508 West Avenue J, to be used for the construction of a new community clinic facility. Ms. Myers.
Thank you, Mayor. So we have some guests with us today from Temple Community Clinic that are going to give you a brief presentation on some of the exciting plans that they have for the clinic location. We've been working together for the past 9 months or so on opportunities for partnership between the city and Temple Community Clinic. And so we do have a site that we've identified that's currently a city-owned property that the city is planning and has plans to move out of and discontinue use, which is the old fire training center on 31st Street. The Temple Community Clinic feels like that would be a really great location for their future investment. And so we wanted to give you all an update today on what they're thinking and planning, and then talk about options for moving forward. So Sherry, are you going to give the presentation?
Yeah, absolutely. And I've got 2 of our executive board members, Jerry Heiss, here with me today. But basically, and what Bryn, thanks for letting us take some time with you today to at least update you about the Temple Community Clinic. So today is more so an overview of the clinic. Most of you are familiar with it, but if you're not, just a quick refresher and tell you a little bit about that and kind of the impact we're currently making in the community, and then what our vision is going forward and why we need to move. So is this?
That should work.
This should work. Okay.
Got Gloria's name on it.
It's got Gloria's name on it. So it's thanks to this nice drawing. This came from KPA. They kind of did a rendering that we're still working on, renderings and kind of layouts for the clinic, but that's kind of a sampling. And for those of you who are not familiar with the clinic is a community-born project that came from a couple of doctors in town, Dr. Jeff Jackson and Gopal Gudakonda, along with the Leadership Temple class, which I know you guys are familiar with Leadership Temple, and many of you have participated in that. I have myself. And it's kind of exciting to see a project like this get off its feet and sustain itself this long. And certainly the City of Temple has been a great partner in that piece. So we're excited about that. Our mission has flexed over the years based on the needs of where that healthcare gap fluctuates over the years. Our board prides themselves by adjusting this to work with the community in their healthcare needs. So you'll see there, Temple Community Clinic is committed to providing quality medical services. And what we've recently added on is that health and wellness education, because that's a big part of people being able to maintain their health, not just placing a Band-Aid, which is most often what free clinics and charitable clinics do, because that's what they have access to is acute care and kind of getting people up and running. but what's more important is to help people sustain their health. So that's our vision. These are the services that we currently offer at the clinic, which is unique to a lot of charitable clinics across the country. Most of them, like I said, it's primary care and internal medicine. You'll see here we offer cardiology, dental, derm, GI, internal med, mental health, optometry, podiatry, primary care, of course, social work, which is probably one of our most recent ads, and women's health. So, you know, we have a vehicle because of the access to medical providers here to be able to support that. And you'll see a lot of pictures over there to the left of our guys in action. This is our current staff. Holly Spin, when I talked about social work, you'll see she's a master's level social worker that we picked up through an internship that we started a couple of years ago. And she kind of heads up that piece. And what was so key about bringing that person on in social work is that then we had a vehicle to bring on interns at no cost. And interns commonly serve 9 months at a time. And so that is instrumental in us being able to offer those additional services and connect people up to the resources that our good community has. Just many people don't know how to reach those. And so that's what our social workers and our interns do. You'll also see that we have an AmeriCorps Vista worker that does a lot of media type work for us, social media, things that we don't want to spend donor money on. So we utilize those folks for that. We also have a recent ad up there. Christy Richter is our new, our first paid provider as a nurse practitioner. She's been with us since March, and we'll talk more about how she was added and why that piece was added, but that has been significant for us and having somebody there all day, every day. So that's phenomenal. All right, community impact. You know, across the country, you know, there's negative health outcomes out there. And when you talk about taking care of people's overall well-being, a lot of it has to do with just lack of education. And so we're focusing more and more on that and becoming closer to our patients and understanding and what their needs are. But you'll see with all of these patients, we have a mechanism now, we brought on technology where we can survey them when they're in the clinic. We got a little tablet with 7 or 8 questions that ask them, where would you go if you could not obtain care at the community clinic? And you'll see the second one, the block, reduction in emergency room visits. 45% of those people surveyed do not know where they would get care. We kind of all know what happens when you don't know where you're going to get care. You go to the emergency room. 29% will tell you that they will go to the emergency room. That is their vehicle for getting care. You know, 13%, they wouldn't seek care at all. That's worse because, you know, health issues just grow into bigger and bigger problems. And then 12% would seek care at another clinic. So when you equate those to savings to the community and those ER visits, we take a modest number, $1,250, and I think everybody knows the emergency room runs a little bit higher than that. But when you average that out, $677,000 in savings for last year, just in avoiding emergency room visits to the community. We asked the same type of question around hospital admissions. 39% of our patients shared that receiving care at our clinic decreased their hospital admissions. Several have, you know, stayed the same, or they haven't visited, you know, or haven't been in the hospital at all. You can see that savings equates to $592,000. That's pretty substantial. And then also something we have access to at the bottom, you'll see prescription assistance programs, vaccines, and over-the-counter meds. Because of our status with the Texas Association of Charitable Clinics and the National Association, we're able to resource places like, or foundations like AmeriCare's, Direct Relief, and other sources where we can get these at no cost for the patients. And so when we add that up for the patients we've had, like $753,000 in savings to the community, so into donor funds. So pretty substantial. All that goes on, and of course the pandemic hit. That was a new thing for everybody, but a big struggle for all charitable organizations. But when it's a clinic and when it's a health issue, it's huge. So it turned literally our world upside down, and we don't have a lot of staff to, you know, redesign everything. We just knew that we couldn't shut our doors because the community needed us, and if we shut our doors, there was just more impact on the health providers that we have in our community. But you'll see that increase. In 2019, went from 721 unduplicated patients to 1,102 in 2020. In appointments, 1,205 to 3,014. And encounters, and when I say encounters, that's appointments, things that we do like refills for people or nurse visit. That's what those are. So that, and this is not people calling on the phone, that's literally doing something for them. That went from 3,075 to right at 5,600. That's huge with the same amount of staff. So that was a tough time. But we managed during that time to keep the doors open, remain access, and that was through just working on getting plenty of PPE in the building, incorporating telehealth, which we know now it will stick with the clinic, and it's been substantial for our patient population. We did screenings and prescription assistance and vaccinations in our parking lot. I mean, we had to find ways to do that. We converted our wellness education series to a virtual format. We responded to an increase of phone calls for support and resources, and then we modified all our clinic policies to incorporate the additional things that we'd have to do to stay open. So last year was a big year for us. A lot of learning. This January to June, this is kind of the numbers presently. We have so far unique patient count is 762, so we're on track to exceed where we were last year. 91 of those are Bell County indigent patients, which is a new collaboration, which some of you may be aware of. Back in October, we signed a collaborative agreement to help serve their primary health care and be a primary care health home for Bell County indigent care. And the reason for that is because we can maximize, we're not really saving county dollars, but we're maximizing the tax dollars they have allocated for that. Last year, their fiscal year was October to the end of September. In March, they ran out of money. So we all came together along with Baylor Scott and White, talked about how we could do that. The county has given us some funding to help us with that, but we're able to take that primary care and provide that primary care health home on the east side of the county. Lane Clinic is doing it on the west side of the county. And so far, we had our last meeting. It's a substantial savings for the county. We are, well below what it would have cost them if they would have kept it the same way. So a lot of things you'll see now where we're giving numbers in that patient population far in the corner. 1,681 appointments so far this year. 378 of those are through Bell County Indigent Health. And so in a total of 5,144 encounters. Other things that we do, you can see prescription assistance where we talked about a while ago, we're saving people. There's that 330,000 that we've done for 117 prescription assistance meds. And then we also the dental piece and vision. So patients are not just getting that immediate need taken care of, it goes well beyond that. These are some of the stats from the surveys that are taken, and I know that's kind of small print, even for me back here. But how would you rate the experience you had at our clinic today? I think that's 96% of those folks give us 5 stars. So with our small staff, we're still able to accommodate these people like they would be taken care of at a regular clinic. How would you rate it? How would you rate as easy as to make your appointment? 91%. Find it easy to do that. Since becoming a clinic patient, as your number of hospital admissions, we talked about that earlier, it's reduced. And 94% say their health has improved since becoming a patient. And you consider us your primary care. It's a huge number in the 90% range. So we've well established ourselves as a primary care health home. And then again, the savings so far this year in emergency room is $528,000 with hospital admissions of $265. So moving forward, you can see, we've advanced. This community born project has moved from just placing that Band-Aid on those folks that are underserved and taking it a step further. And these are the things that we have 3 kind of goals, and we'll go through 3 slides of what we want to do. And then we feel it's important based on the patient population we're serving in our whole overall community is access. If I don't know if everybody knows where we're located. It's a great location as far as in the middle of Wilson Park. It's great, as far as us, we love being in a park. And it's a nice size location. Although we are growing out of it, most people, when we were doing the tours As a matter of fact, we brought the city leadership out first. Fred and Tim came and toured because you've been great partners. But most people that we had tour, they didn't even know we were there. And we've been there for 29 years. So you can imagine what it's like for a patient in need who, you know, they're in a crisis mode. To find us is very difficult, and transportation is always an issue. But our patient population are generally the working people who are uninsured or underinsured. So really most of that population is in the 76504 zip code area, but we serve all of Bell County. So access is important, and it's not about just the patients, it's the providers, being close to medical providers that can drop by and come in and volunteer for a couple of hours and be on their way. Our clinic right now is a little hard to get to, takes more time. And then also just generally volunteers finding us. Awareness, we want to be sure that, you know, our expanded services that we're doing, that they meet the patient's needs, and that people, you know that we're doing those things. The social work is a big piece. So many people need links to get to all the community services we have in Temple. We have most all of them. They just don't know how to access them. So our social work group is a big part of helping them do that. And then capacity, you know, fostering a community that prioritizes healthy living for all. And that's where certainly for our patient population, it's important, but just for our entire community. That's why we developed Living Well in Bell, which we'll talk about in a little bit, is those are free events and they're for our entire community and they're well attended. But we want to promote healthy living for Temple as a whole. So I think I just might turn it off. No, there we go. And then to promote health and overall well-being. Talked about education, Living Well in Bell is important for our patient population. But the last, we have a new one starting up first in person in a while. It'll be August 26th. But those are well attended. The last one was 135 people and we outgrew our location. But some of that's a mix of our patient population and then just general community members. A chronic care program that we developed, and most of that's designed around diabetics and hypertension and some respiratory issues. You know, a doctor can, you know, give all the meds, do the diagnosis, but the education that goes with that goes beyond that doctor visit. And so having a nurse practitioner on staff that can be there, and we set aside appointments to treat that, you know, we want to help those patients move forward, take care of themselves so they don't end up in the ER or, you know, digressing. And then social work, integrating social work into every piece of primary care. Every patient that comes through our clinic all gets a visit with our social work group so they can assess any other needs they might have. And then last, reconstructing the primary care health home for the underserved. So, you know, eliminating that stigma around free clinics. You know, we serve folks that are 300% and 400% of the FPL level. So you can have a family of 6 that doesn't have insurance, or one family member has insurance, and they could be making $80,000, but they still don't have care. And where are they going to go? The ER, because it's too expensive otherwise. We have people that have taken out insurance through the marketplace. Their deductible is $8,000 and $9,000. So they have insurance. They don't have access to health care. There's a difference. And that's what we commonly hear everywhere is, oh, everybody has access to insurance. Sure they do, but they're not going to the doctor because they can't afford it. So that's where we fill that gap. It's not just about what used to be called the working poor or people without insurance. It's beyond that. And so we have to eliminate that stigma. Underinsured and underinsured, as I explained, we're filling that gap. We did change our mission to where we expanded to include underinsured, and that was after the marketplace insurance came out. The deductibles were so high that people still couldn't get care. So we modified the mission to fit the need. And then again, we talked, just to reiterate about Bell County Indigent, is to continue the collaboration with Bell County to maximize those tax dollars. And we're seeing that work out really well, supplying, you know, all that care and only doing referrals to Baylor Scott & White or any other healthcare institution when it's things like MRIs and CAT scans or a hospital admission. Everything else we can do in our clinic. And that's what we're doing right now. So a new location, that whole, can encompass all that is really what we need. We've already have a matching grant through the Carpenter Foundation at $200,000. We have some donors who have already stepped up and met that match. That expires in November. And so we're kind of on a short deadline for that. Pandemic kind of put us, put a damper on things when it came to looking for sites. But I will say Bran and her team have been very, very helpful. We had sites on a couple of other things that didn't come to fruition, but we are running out of time, and we feel like the number of people that we're impacting in our community, it warrants, a site that people can get to and understand what's offered. So that's why we're here today, is we need that help to locate that site. And we feel like this is a great one. Any questions? Or anything, Jerry, you or Michelle would add?
I think you covered
Everything.
Yes.
The site that we're considering is in Midtown Neighborhood Planning District, so it's right, obviously right off 31st Street. It's currently used as, it was formerly our fire training center, and even before that, a fire station. So it's an old facility. It's beyond its useful life. We do still have a couple of crews that are housed in that temporarily while we are working towards more permanent homes. So Transform Temple has a maintenance crew. We do have a plan to move them to what we call the 12th Street shop, which is there near Baker Field. And we're just working on some improvements to that facility that will make that a good home for Transform Temple. And then we also have an aquatics team that currently is housed out of that. Their ultimate home will be at our parks administration, or our parks facility. We are asking you to reject bids today on the parks, an improvement that would have been helpful in moving us along there, but we still, we're working through options, and that's still the plan. It just may take a little bit longer. So we feel fairly confident that we'll be able to make the operational improvement or changes we need to make to vacate the facility. That was already in our planning process. We've actually already budgeted for the demolition of the facility.
And the thing behind it.
And the tower. Yes, ma'am. Yes, ma'am. It's I'll give you a piece of it.
It's not that
But it's still coming down.
Yeah.
It's not a particularly, I think a facility of this nature will be just a great addition to the neighborhood and into that corner, into that important, visible corridor. So from a staff perspective, we feel we visited with utilities and other departments to make sure that there's not either short, mid, or long-term use we see from a city perspective for utilities or any other reason. There are some ground storage tanks that are adjacent to that site. It's nearby the Avenue G pump station, which we have under design for rehab and replacement. We did evaluate the fire training center site as a potential place for the Avenue G pump station and then we also evaluated two other options. The engineering work that came back on that recommends not this site, but rebuilding the pump station where it is, so that there's really not, we haven't identified a long-term city use for that facility. So from a staff perspective, we feel comfortable moving forward with a property transfer agreement similar to what we did with Family Promise recently. If council will recall, under a property transfer agreement of this nature, the facility does have to be used for a public purpose. Jerry mentioned their contract with the Bell County for the Indigent Health Services. So I think there's a pretty clear link to a public purpose that could be established. The grant, their deadline for moving forward is at the end of November. So we wanted to bring this forward to you for discussion today. And assuming you all kind of give us the green light, we'll continue to work together on bringing a property transfer agreement back to you for your consideration in the next few months. We believe that will give the community clinic what they need to move forward with their grant. And we envision that probably the closing date or the actual transfer of the property would be at a future date to allow us to make sure that operationally we're able to adjust for aquatics and transform Temple and get the site demolished so that it's handed over in a fairly clean way for them. So that is our kind of our next steps, assuming this is something that you want to work continuing to work through.
What's the estimated cost to build the new facility?
Well, now that building has really changed over the past several months, we know that $2 million is probably what we're looking at, but with building costs right now, I'm not gonna throw a number at this point. It's kind of dangerous to do, but we know we're looking anywhere from 10 to 12,000 square feet. And one thing I did want to mention in that, we are incorporating a community space that will allow us to hold the educational series and any other teachings that we have there that we'll be able to share with the community. It should seat, 200, 225, somewhere in that range. So that's something we'll be able to, we want people to come and participate in their organizations to do things. So that site will be available, outside of the things that we do, because that education series is important to us. And currently we're holding it at TISD's location, CAC. We're having to look for facilities that are not always going to give that to us for free. It can be very costly. So that's important to our function in the community, but also it's something we can share with the community, because that's something that's a need. We know community meeting space of that size is, you either have smaller or you have really large, nothing in between. So another opportunity to be a good partner in the community.
Well, I'm 100% behind the free clinic. Experience it with my own family, and so it was, when he had a stroke, it was very helpful that we were able to use that. So it's real critical that we have that. I guess my question right now is, you said most people come from 76504. Is that going to still be 76504?
I'm not sure of those lines. It's very, very close, because I know it's around the Scott and White area and 57th Street. All of that encompasses that. But quite honestly, we have patients, Troy, Belton, all over the Temple zip codes. But what's more important than we recognize with our patients is that it needs to be where they frequent. Baylor, Scott and White, where they get food access, things like that. It needs to be in proximity to that. There is also a hot position there very close. Currently we don't have that at the clinic where we are now. So we need to be where our folks will frequent.
I'm just with District 2. It is a long way, and Temple is really growing. Just want to be sure we
Sure.
plan our transportation and be sure that it includes.
Right.
Because don't forget, it's on the hop line, whereas presently they are not.
Right, we're not, and then we're just far removed from all the things they have to access. And so it makes another challenge of transportation that they have to go back and forth. And that's what we hear. Which sometimes they go, I'm just not gonna do all that, I'm just gonna go to the emergency room. It's much easier,
When you're right.
and they do. So I think because access through Avenue H coming up, from I-35, very easy access there. Then all along 31st Street is obviously easy access, and you're less than a mile from Baylor Scott and White. So it's easy for them. The emergency room here does a great job of saying, okay, you're here for sore throat, really need you to go over there, and when we're way over there and around the bend and back, they're like, yeah, I'm not doing that. So it'll just anything on 31st Street.
They will get there.
Yes, they will get there. Much easier, yeah.
I'm excited about this. I think it's going to be great for the community.
Mayor Brand asked me to meet with Sherry, and I met with Sherry and Jerry. Michelle couldn't be there in 2019. And frankly, I had lost track of you in the intervening time. I really want to congratulate you on rewriting your mission and adding the uninsured. Underinsured. That is so important, so important. And I met with you because you were under consideration of a site somewhere in District 3, off of 5th Street, I think. I'm not even sure now. But this is in many ways a better site because it's right on the hop. more well known, if that's correct grammar, I'm not sure. But thank you very much for the presentation.
Well, we find, we talk about uninsured, we have folks that their spouses are working in the industrial park, they're working for the county even, and they're insured,
Right,
but their spouse
it's not.
is not. And we know commonly for them to insure their spouse, it's anywhere from $800 to $1,000 to add their spouse. Well, that's just not feasible. So generally the spouse goes without insurance, and that's a huge disadvantage. So that we fill that gap many
Yeah,
times.
that's a huge gap in insurance across the country.
Right.
One of your slides showed how y'all are diverting people out of the emergency room.
Mhm.
And that's a cost savings to our healthcare partners here. And you're also saving the county some money. I'm sure that those two entities are aware of those numbers.
They are.
Do they ever say thank you?
Baylor Scott White, their providers, many of their providers have been coming to our clinic. I mean, I've got 3 that are out there right now, been coming over 11 years, and they come every week. And all your specialty clinics, Baylor Scott White makes it feasible for them to come and do those, and to have a cardiologist and GI and all those specialties, and they're hard to get. They've been coming out for a long time. So I would say that Baylor Scott White has been a really, really good partner, and several of those guys sit on our board. And that relationship has always been good, because without those providers, we can't do it at all. We just flat can't do it. I mean, one provider is costing us $150,000 a year, and we were only able to add that because of the county funds. And that was necessary for the county, which is serving them well over that, but it's also helping us as a community and to see more patients and more frequently. So I would, and they've also done, grants periodically. We do grants for chronic care programs. So they are doing that. The county funds are substantial. We have a meeting with them every 3 months, give them the numbers. They're very happy, to your point, of what's being accomplished, and they don't have to worry about running out of money in that space. I'm sure that eases their
Was it
mind.
2 years ago they ran out of money? 3 years?
Last year, and
Yeah.
the year before that.
Yeah. Maybe it showed up in the telegram 2 or 3 years. I remember it being a very big
Yeah.
number.
But it's very scary. And when that happened last year, it puts the brakes on everything. So when they can interview people, they can't give them care. And so what they do is all those people divert to the emergency room. Well, then Baylor Scott White's like, okay, wait, this is not the route to take. So we basically all 3 came to the table and said, okay, let's talk about how we can make this happen. And Baylor Scott White, will you help us in kind take care of the, whether it's inpatient or MRIs or CAT scans, things like that. And so they're doing that.
Good.
The county billed out last year, I mean, these numbers are out there, over 18 million to Baylor Scott White is what was billed to them for seeing Bell County indigent patients and taking care of them. They were reimbursed $2 million. So the rest was written off.
So it's all good partnership. I mean, it's working.
Yes, it's a very good working relationship, and all of us came to it's like, unless all 3 of us can come to the table, it's a no-go.
Right.
And it was that way for a while. We really had to sit down and go, it has to work in all these spaces before we can actually do it.
Good.
So,
Very
And
good.
one more thing, I'm really excited that you're adding more health services.
yes.
That's a big need in our community.
And that's a resident rotation out of Baylor Scott and White. They provide a resident that does a rotation along with Dr. Hicks. And so that's 2 opportunities. And then our master's level social worker it also delivers therapy. So she's able to do therapy at the clinic. So that's huge. Most charitable clinics, that's not offered. And that has a wait list already, along with dental. There's no fix for dental, really. It's tough. But we've got about 10 dentists that provide us appointments that we're able to send to their locations. That's what they prefer. And they grant us that. So anybody in your dentist wants to donate an appointment, we'll take it. But that's how that works. So a lot of great partnerships in our community. It's just a matter of reaching out there and asking for them. Another thing that's really important to you guys and everybody, all of us as taxpayers, is that we are so busy resourcing outside of this community for many of the things we get. During the pandemic, we resourced $131,000 worth of insulin. Didn't come out of this community, didn't come out of our donor funds, came out of other contacts that we have. And because we meet the standards for the National Association and the Texas Association, we can source things that none of us have to worry about paying for. And the county sees that value too, is they don't have access to that.
I think the other positive thing about this location is just the visibility for the
Yes.
community clinic to the community.
Yes.
I'll have to be honest that while I knew of the community clinic before Michelle and Sherry invited me out for a visit, a year ago, I really didn't fully understand what amazing opportunity was there. I grew up in a very low income family when I was young. We didn't have insurance, and I think sometimes even just the dignity that comes from being seen in a clinic that feels like any other, clinic and the services they provide and the way that they go about it. It really impressed me, and I'm really thankful that we have the resource here. And so I'm excited. If I didn't know, and they're, in a space that's owned by the city, I think that this location will also just increase the visibility of the organization as a whole for the community. And so I think that's another benefit to the location.
Very good. Council, anything else? Thank you for your good work. All of you.
Thank you.
Very much. Yes.
I'll answer your call next time.
It's okay.
I get it.
Thank you very much.
Thank you.
All right, moving on to item number 5 is to discuss the proposed fiscal year 2022 business plan, including but not limited to the proposed fiscal year 2022 annual budget. Ms. Myers.
Mayor and Council, this is just a standing item that we're gonna have on your work session agenda from here until we are scheduled to adopt the budget on August 13th. So I don't have a specific presentation today, but I do have my full presentation from last time. If you wanna have any, I'm ready to go. If anyone has any additional questions, or if you've got any topics that you would like staff to bring back for a deeper dive at a future work session, definitely let us know. We do have an item on the regular agenda tonight where you're going to have your initial public hearing on the city budget. So I will do a much abbreviated presentation during our regular meeting tonight, and you will hold your first public hearing on the budget, and then you are also setting the date and time for the public hearing on the proposed tax rate, as well as scheduling the adoption of the proposed tax rate. So beyond that, I would love to go into detail about anything you want to, but it's really guided by you at this point.
Brent, I met with the Parks Board yesterday, their monthly meeting, and Kevin presented the Parks portion of the budget, and the board was fine. Nobody jumped up and down and screamed. Of course, want more.
Yes.
Which I have told you what we want. Notice I say we. But anyway, it was fine.
One of the, just speaking of parks, one of the things I'm particularly excited about presenting was the capital replacement project, where we're going to be able to do some, assuming you all agree and support that, we're going to be able to do some upgrades to our park system as we go along, and not rely only on large bond issuances to handle kind of the ongoing replacement and maintenance of our amenities. So I think that'll make a big difference. We haven't had that in the past.
I don't have anything for today.
So Mayor left us.
Obviously, he doesn't have anything.
Mayor Pro Tem, would you like to close us out of our, I'm sorry, read us into our executive session? I'm gonna, yeah. I guess you have that language as well.
Okay.
You'll just read that in.
3:34.
and pursuant to Texas Government Code Section 551.072 and .087, council may meet in closed session to discuss or deliberate the purchase, exchange, lease, or value of real property of deliberation. In an open meeting would have a detrimental effect on the position of the government body in negotiations with a third person. Discuss or deliberate commercial or financial information received from a business prospect that the governmental body seeks to have locate, stay, or expand in or near the city of Temple. And with the governmental body is conducting economic development negotiations or to deliberate the offer of a financial or other incentive to such a business prospect. No final action will be taken. Yeah.
I stepped out the right time.
Yes, you did.